Hello, I am Dr. Nesmani, and this is the 6th session of the Surgery Postgraduate Medical and Test Practice Session 2012. Please visit the channel youtube.com/acpgmed, also facebook.com/acpgmed. You can see the previous videos uploaded in the channel youtube.com/acpgmed. Question number 21 in the surgery series. 20 questions have been already discussed. Please visit the previous video upload to keep track of this video series. In this question, which of the following surgical interventions is least likely to provide acceptable prolongation of life for patients with AIDS? Splenectomy for AIDS-related idiopathic thrombocytopenic purpura, or colonic resection for perforation secondary to cytomegalovirus infection, or cholecystectomy for acalculous cholecystitis, or tracheostomy for ventilator dependent patients with respiratory failure, or the gastric resection for a bleeding gastric lymphoma or Kaposi sarcoma. So which is the least likely to provide acceptable prolongation of life? That is means bad prognosis. Answer is D, because the patient who has AIDS frequently present with problems that potentially require surgical care. The involvement of the surgeons with these patients will increase as more effective treatments are developed and the AIDS patient survival is prolonged. AIDS patients not only suffer from common surgical illness, they also develop problems especially associated with their altered immune status, such as bleeding from gastrointestinal lymphomas or Kaposi lesion, bowel ischemia, perforation from parasitic or viral infection, acalculous cholecystitis and retroperitoneal and intraabdominal masses due to massive lymphadenitis. But with the exemption of the tracheostomy, experience has demonstrated that surgery can be performed with acceptable morbidity and mortality, and that it seems to provide comfort and prolong quality life. Though it may facilitate nursing care, tracheostomy does not reverse or slow the pulmonary failure once the patient has become ventilator dependent. So it is not the procedure but the patient's capacity to survive. Airway access for mechanical ventilation can be provided either by endotracheal or tracheostomy tube. During episode of acute respiratory failure, patients are generally ventilated through an endotracheal tube. Changing to a tracheostomy tube is often considered when the need for mechanical ventilation is expected to be prolonged, which means the patient's respiratory condition is worsening. The advantages of tracheostomy and disadvantages of tracheostomy are there on your left side. Ease of replacement once tract has formed. Speech, mobility and swallowing are enhanced. Patients can be nursed outside the ICU. Ease of suctioning and patient comfort are the advantage of tracheostomy. But the disadvantage of tracheostomy are complication at cuff size, stomal complication, contribution to ultimate laryngeal injury, tracheo-innominate artery fistula formation, increase in pulmonary infection, mediastinum may be attacked by infectious agents, high mortality for inadvertent decannulation. The advantage of intubation or rapid insertion by skilled consultant in most settings, lack of need for surgical procedures, so risk and expense are decreased, and lack of stomal complication are the good things of intubation. But the bad things about intubation are complication at cuff site, laryngeal complication, replacement requires skill at times and generally requires ICU level, suppression and injuries at nose and mouth. So Kaposi sarcoma is a low-grade vascular tumor associated with infection with human herpesvirus 8, also known as the KS-associated herpesvirus. KS has been classified into 4 groups based upon the clinical setting in which it occurs. Classic KS is rare intracutaneous proliferative disease that primarily affects older men of Mediterranean and Jewish origin. The endemic or African form of KS is found in all patients of equatorial Africa, particularly in sub-Saharan Africa. It is not typically associated with immunodeficiency. Organ transplant recipient, KS occurs after solid organ transplantation, presumably due to immunosuppression. In addition, transplant itself may transmit HHV-8 infection. Then AIDS-related or epidemic case is particularly prevalent in patients infected with HIV. Before the introduction of highly active antiretroviral therapy, that is HAART, the prevalence of case was around 20,000 times higher in patients with AIDS than in the general population. Use of HAART has led to a marked decline in the prevalence of AIDS-related case, and patients receiving HAART present with a less aggressive case and have significantly decreased morbidity and mortality. Next question, number 22. An elderly diabetic woman with chronic steroid-dependent bronchospasm has an ileocolectomy for a perforated cecum. She is taken to the ICU, intubated, and is maintained on broad-spectrum antibiotic, renal dose dopamine, and rapid steroid taper. On postoperative day 2, she develops fever of 39.2 degrees Celsius, hypotension, lethargy. Laboratory values remarkable. For hypoglycemia and hyperkalemia, the most likely diagnosis of this acute event is sepsis or hypovolemia or adrenal insufficiency or acute tubular necrosis or diabetes ketoacidosis. Which one is your choice? The answer is C, that is acute adrenal insufficiency is classically manifested as changing mental status, increased temperature, cardiovascular collapse, hypoglycemia and hyperkalemia. Diagnosis can be difficult to make and requires a high index of suspicion. Its clinical presentation is similar to that of sepsis. However, sepsis is generally associated with hyperglycemia and no significant change in potassium. The treatment for adrenal crisis is hydrocortisone 100 mg intravenously, volume resuscitation, other supportive measures, and to treat any new or ongoing stress. Then 200 to 400 hydrocortisone mg is administered over the next 24 hours, followed by a taper of the steroid as tolerated. Symptoms and signs of adrenal insufficiency depend upon the rate and extent of the loss of adrenal function, whether mineralocorticoid production is preserved, and the degree of stress. Although many of the symptoms are similar in patients with primary or secondary tertiary adrenal insufficiency, there are some important differences. Acute adrenal insufficiency, the syndrome of adrenal crisis or acute adrenal insufficiency in adult may occur in the following situation. In a previously undiagnosed patient with primary adrenal insufficiency who has been subjected to serious infection or other causes or acute major stress. Then in a patient with a non-primary adrenal insufficiency who does not take more glucocorticoid during an acute infection. Can occur during acute viral infections such as influenza or other major illness, or has persistent vomiting caused by viral gastroenteritis or other gastrointestinal tract disorder. Then after bilateral adrenal infarction or bilateral adrenal hemorrhage, and finally rarely in patients with secondary or tertiary adrenal insufficiency, but it is sometimes seen with acute cortisol deficiency due to pituitary apoplexy, or in patients withdrawn abruptly from suppressive dose of corticosteroids like nephrotic syndrome and bronchial asthma. The predominant manifestation of adrenal crisis is shock, but the patients often have non-specific symptoms like anorexia, nausea, vomiting, abdominal pain, weakness, fatigue, lethargy, fever, confusion, and coma. The laboratory findings suggestive of clinical and laboratory findings suggestive of clinical adrenal crisis are dehydration, hypotension, shock out of proportion to severity of current illness, nausea and vomiting with a history of weight loss and anorexia, abdominal pain, the so-called acute abdomen, unexplained hypoglycemia, unexplained fever, hyponatremia, hyperkalemia, zotemia, hypercalcemia, eosinophilia, hyperpigmentation, vitiligo, other autoimmune endocrine deficiency like hypothyroidism, gonadal failure. Chronic adrenal insufficiency, primary. Most common clinical feature of chronic primary adrenal insufficiency are chronic malaise, lassitude, fatigue, worsened by exertion and improved with bed rest, weakness, anorexia and weight loss. Hypoglycemia is not common. The manifestations of chronic adrenal insufficiency are symptoms: weakness, tiredness, fatigue, anorexia, gastrointestinal symptoms, nausea, vomiting, constipation, abdominal pain, diarrhea, salt craving, postural dizziness, muscle or joint pain. The signs are weight loss, hyperpigmentation, hypotension, that is systolic BP less than 110 mm mercury, vitiligo and auricular calcification. Laboratory features are electrolyte disturbance, hyponatremia, hyperkalemia, hypercalcemia, zotemia, anemia and eosinophilia. Secondary or tertiary adrenal insufficiency. Many of the symptoms of secondary or tertiary are the same as those of primary, but are presumably due to glucocorticoid or the mineralocorticoid deficiency. These include weakness, fatigue, myalgia, and arthralgia. Major difference from primary and secondary are hyperpigmentation is not present because ACTH secretion is not increased, dehydration is not present, and hypotension is less prominent. Hyponatremia and volume expansion may be present, but hyperkalemia is not, reflecting presence of aldosterone. Gastrointestinal symptoms are less common, suggesting that electrolyte disturbance may be involved in their etiology. Hypoglycemia is more common in secondary insufficiency. Hope that this session was useful to you. Next session will be uploaded Please visit the site www.youtube.com/acpgmed. You can also write to me in the address acpgmed@gmail.com or drnsmanimd@gmail.com, drnsmanimd@gmail.com. Thank you.